Now we proceed to the next talk. The next two talks are by Dr. Mahesh. Use of OCTA in current scenario, OCTA, and followed by the rapid fire quiz. Okay, over to Dr. Mahesh.
Thank you. Hall nalla thanupayathu karana njan avade irunnu orangayirunnu. So most of you. Anyway, I will talk about OCTA in the current scenario. OCTA is there in many centers now and it is being used. OCTA has not replaced the OCT, dye angiography in our management of retinal diseases. So we'll go through some of the why it is not replacing OCT, dye angiography. Because if I ask which is the abnormal vessel, which is mature vessel, inactive vessel, can you tell which is leaking vessel? It all looks like the same. Some are thin, some are big, some are small bunch, some are large network. So it is very difficult. It is just looking at the menu and ordering in a Chinese restaurant. So it is extremely difficult. So that is why we don't use OCTA alone unless you are very expert and you know what to look for. So there are different types of networks seen in OCTA, in AMD, Medusa head, C-fan, prune tree, and mature trunks. Lot of types of vessels are there. So let me tell you that there are type 1 CNVM or MNV, macular neovascularization, type 2, type 3. Type 1 is sub-RP, type 2 is pre-RP, and the other one is third, type 3 is RAP, retinal angiomatous proliferation, where some things are happening in the retina down. So these three will have different findings. Like this is a in the OCT, you can see a hyperreflective double layer sign in the upper left, this thing. And where there is a hyperreflective double layer sign, there is a network underneath, which is having a medusa pattern in type 1 CNVM. So this is another case of type 1 CNVM. You can see a thin filamentous network with surrounding halo or hyperreflective area, which is due to some fluid around. So the vascular density is very high, unlike a mature large trunk where vascular density is less. Okay, so this is type 2 or pre-RP. This will be, the network will be growing from under the RP to the pre-RP space. So it will be a small bunch, but very dense. You can see that it is a small bunch, but very dense with more SRF and subretinal and intraretinal fluid. So this is a classic CNVM, old terminology, classic CNVM. So you can see after injection how the vessels have changed. It has not disappeared, but it has reduced significantly after the injection. Then type 3 is RAP, where there is a medusa head. You can get the, actually RAP also you can diagnose with OCTA, where there is a clinical signs and OCTA. So this is how we use OCTA. After 3 injections of anti-VEGF injection and 3 anti-VEGF injection, you can see that vessels have become less, the network have reduced, vessels have become more stouter and larger, so it's becoming a mature vessel. But when the reverse, PCV also can have different patterns in OCTA. You can get a network as I showed in the hyperreflective double layer sign, and it is little difficult to get the polyp in PCV because at the thumb-shaped PED tip, there will be a polyp which may not be high flow. The flow in the polyp may not be high, so that the OCTA may not show the polyp very clearly. But you can get the polyp as it is seen in the right picture. So we use it for follow-up when there is no activity. The top one has no activity. I don't have the OCT picture corresponding. No activity. It's a large mature trunk. OCT is dry. The next one, you can see that network has become more filamentous area, more thin vessels are growing, vascular density is increasing, and correspondingly you can see that IRF has started. That is activity. So you inject again. So this is worsening after in OCTA. So this is a very useful tool for follow-up. That is what I want to tell. So you don't have to repeat angiogram every time, and you know which patient to go to treat and extend regimen and which patient you can use on PRN based and all. So very useful. So that this is the main thing that we are using in neovascular AMD and PCV. Now I will tell some other classic uses of OCTA. You can easily detect ischemic maculopathy if it is RVO. If the patient has, we cannot do dye angiogram. We don't do dye angiogram very frequently in RVO and all. So you can have some biomarkers in OCT like this drill. The top picture left side, you cannot make out the layers of inner retina. So there is a disorganized retinal inner layer, and in fact that corresponds to the superficial and deep vascular plexus network abnormality in OCTA, which you can call it ischemic maculopathy. PCN or pachychoroid neovasculopathy is a condition between pachychoroid pigment epitheliopathy and PCV, polypoidal choroidal vasculopathy. So sometimes it may be looking like a CSR. This is a case where you can see that it's only looking like a CSR, but there is a large vessel there, the arrow is there. So at that area you can see a clear network of vessel. So there is an underlying pachychoroid neovasculopathy which is somewhere between the PCV and CSR. This is very useful indication, that is myopic CNVM. The classic investigation to diagnose a myopic CNVM is dye angiography. So you can see a nice hyperflective subretinal lesion, and in the angiogram it is profusely leaking, which after injection it reduces. But the OCTA is equally useful, which shows the network very nicely, and after injection the regression and the mature vessels are seen. So in active myopic CNVM and inactive myopic CNVM, OCTA is a very useful imaging tool. So active myopic CNVM is the top left and inactive myopic CNVM is right side down. So this is a very useful in follow-up. Unexplained visual loss in diabetic retinopathy with nephropathy. As I told in the central retinal vein occlusion, RVO, here also you can easily diagnose ischemic maculopathy, which is the cause for unexplained loss of vision as the old teaching goes. So that is one. Then there is something called non-exudative CNVM, which can be detected only by OCTA, not by dye angiogram, because it doesn't leak. There is no exudation. So this was a case left, both eyes had CSCR, pachychoroid spectrum. One eye had chronic CSCR-like picture, and that eye was having injections. The other eye also had problems. So left eye, already multiple doses of anti-VEGF Eylea was given, and the vascular, but in the other eye, where there was no fluid, clinically, there was a network. It's a silent network. Though this is an indication that this patient also will go for macular neovascularization and defective vision, so they have to be followed up very frequently. CNVM in CSR is another thing. Already it is in the same spectrum. Sometimes where there is a diffuse leak, it's not a typical ink blot or smokestack, and there is some irregularity in RP, you can get a network underneath, somewhere between CSCR and PCN. Multifocal choroiditis, these are all rare causes. All these cases, you don't, this inflammation, the problem is in dye angiogram, there will be lot of leakage due to inflammation itself, like disc leakage and other vasculitis leakage. You don't see whether there is any network. So in inflammation like this, the network can be very clearly seen with OCTA. So this is in angioid streaks, very useful investigation. Angioid streaks, you can get a nice specific type of network. VKH with, these are all very, very rare things, but if you want to differentiate that there is something, if there is a hemorrhage which we don't get in ordinary VKH, you can get that network here, and it is. So in toxo, this is a very rare case, but when you see a hemorrhage in a toxo scar, there could be a neovascularization which can be confirmed by OCTA. So these are the type of this thing, angioid streak, another one more angioid streak. So this is the leakage, very small leakage, which you can get. Very rare causes, one coloboma with edge, one exudation is there in that area. The angiogram is showing some diffuse leakage, you're not sure what it is. What in the OCTA, you can see a network at the edge of the coloboma. So current uses of OCTA are follow-up of neovascular AMD and PCV, very useful. PCN diagnosis, non-exudative CNVM, myopic CNVM, where you cannot do dye angiography in ischemic maculopathy. and when the leakage is very indistinct and uncertain, like some inflammatory pathology, you can find the network. So these are the uses of OCTA in the current practice. Thank you very much.